what is beginning to happen is in the past we were in that fee-for-service world, and cardiac services in many ways was the poster child for fee-for-service medicine. It was great. Someone was sick, they'd come in, we'd put in a stent, we'd do this, we'd do that, make them better, they'd go out, we'd get paid, everybody was happy. Well, now what's starting to happen is we're starting to see a situation where the risk curve is shifting. In the past, if you look at this sort of cyan-colored line, you would see that the payers had all the risk. We did a procedure, we sent them a bill. They might pay it or give us a hard time about it or try to deny it, but generally we got paid. But now you see that the orangey line is starting to rise up here, and we are starting to take some of that risk. So what does that look like? Well, if you believe the Center for Medicare and Medicaid Services, CMS, by 2018, 50% of payments will be linked to alternate payment models. What does that mean? Alternate payment models means you, the healthcare providers, that's the hospitals and the physicians and everybody else associated with us, take the risk. And so fee-for-service will begin to decline. And that's what you see as that orange bubble starts to grow in size. And if you look at this in another view, we already are starting to see some of these penalties, mostly from the government programs, from Medicare and Medicaid, but our patients in the cardiac service line, a lot of them are over 65, so we do have a huge number of patients that fit within this category. And if you look again and see that as we look towards 2017 on the right side of this graph, you see that the blue, the value-based purchasing, the orange, the hospital readmissions reduction program, and the last one, the hospital acquired conditions reduction program, which is usually more about infections. These are assuming greater and greater risk for us. So by 2017, which is of course just 2 months away, approximately 6% of our CMS payments are at risk. Now, I don't think I have to remind you, but I will. In the cardiac service line, if you look at the percentage of what is supported in terms of everything from physician salaries through the nurses, the NPs, everything that supports the cardiac service line, the purchase of every expensive catheter that's being sold on the side over there where you had breakfast, every single dollar that is coming there is coming more and more into risk. And therefore, I think it's extremely important for the leaders in cardiology to be extremely conscious of where the risks are and to think how you can work with the healthcare providers, the systems. I happen to be a cardiac anesthesiologist, so I understand a little bit of this, but think about how many of your institutions have someone who understands the cardiac service line in the senior leadership. Not that many. So it's your job to think about how you can facilitate the best possible financial support situation because your hospital's paying the bill for this cardiac service line and they're at risk and you have to help them do better in this new payment model. So what about this? Well, it isn't just the federal payers. Look at Aetna, Cigna, Emblem, Empire Quality Health Program, Health First, which is a managed Medicaid program that we have here in New York, United Healthcare. If you look at these numbers, you see that even the private payers also have now negotiated with us risk contracts. Everyone's different, so it becomes an alphabet soup, difficult to understand, and I'll try to explain a couple of the alphabets in the soup, but the challenge is that you have to start thinking very differently. We have leadership I was very pleased to meet here from the ACC, and of course we have the STS, and you have many organizations in the cardiac service line that focus on creating appropriate guidelines, and more and more as a profession you've led in the world in terms of being your own policeman in terms of creating quality metrics. But those quality metrics are not necessarily what the payers and the government payers are going to pay attention to, although they're often closely related. So let's talk about that. What this graph shows, again, is another concept of the shift. And what you see is that right now the program is at a maximum of 2% of Medicare payments. That's the value-based purchasing. But the process of care measures are going away. So, for example, even though we're still working on it, the concepts like door-to-balloon time, that's a process measure. That's not an outcome. What is an outcome? I'll get to those in another slide. And also infection prevention measures are now coming on board. You might think, we don't have infections. Well, you do have central line-associated bloodstream infections. You have catheter-associated urinary tract infections, especially when your patients are in intensive care units. So this is not something that you need to ignore, or you should ignore. It's something you should pay attention to. And then 2017 performance periods, you're going to see on the extreme right there, that clinical care outcomes, mortality, and safety, PSI 90 is sort of a basket of different safety metrics. Although these numbers look back almost 2 years, they're taking increasing importance. And when we blow it up a little bit to 2017, I want you to notice just how important cardiac is to these outcomes. So if I can, let's see, where's my is this the... I did it wrong. Let's see. I'll go forward again. My little pointer. There we go. Mortality 30 AMI, 30-day mortality for acute myocardial infarction. That's your business line. Mortality 30 days, heart failure. That's you. AMI 7A, well, maybe not so much for this audience, but this is starting fibrinolytic therapy within a certain number of minutes of all the patients who get fibrinolytic therapy, but this is more of a catheter crowd. And then the others are not so much associated to you. This is influenza, and that's perinatal care. But within the safety realm, central line-associated bloodstream infections, urinary tract infections, MRSA, C. diff, and then that bundle of all sorts of complications called PSI 90, which I really don't have that much time to go into. But I'm going to jump back up to the top. Patient satisfaction. Don't be a jerk. Don't let your teams be jerks. Be nice. Be focused on patient experience. Patient experience, self-reported patient experience, is assuming more and more of a role in determining payment to hospitals, meaning the payments that support everything that you do. Let's see, switch back to the other toy here. So, also post-acute care. All right, you have a sick patient, very, very sick. They came from a nursing home. They go back to a nursing home. So far, the bundles, the cardiac bundles that have been put together have been for the surgical interventions, for the valves, for the coronary bypasses. Don't worry, you're coming. Just a matter of time. So think about what the bundles mean. And over time, what has happened, when you look at this nation, you will see that since the introduction of the DRG system, the length of hospital stay in this nation has gone down. But the amount of resources and dollars associated with post-acute care, skilled nursing facilities, visiting nurses, physical therapy, cardiac rehab, it's skyrocketed, and Medicare has noticed. And so the bundles hold you responsible with these post-acute providers, and you have to come together and create strategies so that you do not overspend on your bundle. And here's a little cute thing that we're playing with right now. We're not proud here of our heart failure readmission rate. It's too high, way too high, and we're working on it. Part of it is, of course, that we're on that borderline between wealthy Upper East Side and very non-wealthy East Harlem. And we have a mission. We're devoted to caring for all of our patients. And the East Harlem population is very challenged. They have socioeconomic disadvantages. They have lack of primary care. They have all of the ills that we've created as a society, or that society created and we suffer from, related to problems of just not being able to care for themselves well. So we're trying to think about how we deliver that care post-acute in a more effective fashion. And so, for example, this is a cute little app that we're piloting right now with the help of our heart failure team, where we discharge patients with a blood pressure cuff that can and a scale where we can have our nurses monitor the patient's blood pressure, pulse, and weight on a daily basis, and politely remind them if they don't do that on a daily basis, and intervene if we see people going in the wrong direction. Heart failure is a real problem. And a lot of your patients will fall into this category because it isn't just, let's say, that they're here for a valve intervention or a coronary intervention. They're in that heart failure bucket. So think about what you'll be able to do working with your teams to create cost-effective strategies towards reducing those 30-day readmissions. So I think we're nearly at the end here. So I just want you to focus on one thing. When we look at the bundles in surgical interventions, cardiac valve and coronary bypass, in contrast to the post-acute, which is so important in joint bundles and major joint surgery, a lot of it's still in the hospital. So I want you to think about those companies outside. I'm glad they supported this conference. I'm glad they're supporting your education. But every dollar that you pay for a catheter, if you have a group in your hospital that wants to have access to 5 different companies that do the same thing, all of that inefficiency in your inability to negotiate the best possible pricing for your institution takes dollars away from other things that you need to do within your cardiac service line. And so within cardiac service lines, because the stuff we use is so expensive and our staff are so expensive, we have to think about making our enterprise more efficient. And so I believe that is getting to the end, and this is my last slide. This is something called excess days. We talked before about reducing length of stay, but it isn't just about reducing length of stay. It's reducing length of stay related to the expected length of stay. And so if you just divide that out and you take out the days you've gotten rid of, those are the excess days. And I want you to notice in this particular slide that right now we're not doing so well on CHF. We still have 87 extra days that we wanted to get rid of. We've done very well with our intensive care units in getting rid of excess days related to respiratory failure by focusing on earlier tracheostomy and working with palliative care teams and physical therapy and early mobilization, all that, mom and apple pie kind of stuff that is common sense. But we still have our challenges, and I wanted to show you that CHF, again, continually pops up. So this is your expertise. This is within your service line. So think differently as you go forward. Be wonderful clinicians, be expert technicians, be great scientists, but in addition, be smart, because the economics of medicine are a limiting factor. And you, as people who are leaders in the cardiac service line, have a responsibility to think in new ways and to educate the people that work with you and to become their partners in creating a more efficient and effective healthcare delivery system. That's the challenge of the next 10 to 20 years. And we didn't have to think this way in the past, but we do in the future. So please join a simple cardiac anesthesiologist who enjoys going to the OR still 3 or 4 times a month. I'm a recovering chairperson. I gave that up, but I'm not a recovered cardiac anesthesiologist. I love what I do. I love the cardiac service line. I love being in the OR. I love being in the intensive care unit. And this is my home. And so what I say to all of you is you are my people. And as my people, I encourage you to take a leadership role and to take responsibility for the future of delivery of cardiac services in this nation, and I think you will do a superb job of it. So thank you for allowing me to address you for a few minutes.